sitting in lectures that I'm giving, God help them. We also have representatives at HHS, from the last administration and from this administration, HHS being the Department of Health and Human Services in the US, saying long COVID is a problem, chronic Lyme disease is a problem, ME/CFS is a problem. And, and that is the last two administrations that have been saying that. And I think that that was not something that was being said previous. Okay. So I call that progress.
And you haven't met any major roadblocks yet under the present administration with respect to
in fact, thankfully under the present administration, I was invited to DC to speak about long COVID. The manual that we created that talked about our clinic's approach to treating long COVID is now actually prominent on the HHS website as a downloadable resource that anyone in the country can download for free. It has been encouraging to see, that this is a bipartisan issue. I do think to some extent, my own observations for what that is worth on this topic is that COVID has touched everyone. COVID doesn't care if you're a Republican or a Democrat or, left or right on the political spectrum or right in the center. It's touching everybody. Everybody has a story about long COVID, even if they don't know that it's long COVID. Everyone has a story of just not being the same after, a viral hit. And although post-acute infection syndromes, infection-associated chronic conditions existed beforehand, it does seem that COVID is that much more effective at causing them, according to the existing data that we have. And so I think that, there is a much larger sort of groundswell of people saying, hey, we need some help here, and we don't really care who gives it.
Okay, I guess that's almost hopeful.
It's almost hopeful.
it's a message, but there's a critical mass almost of people, but so often and until very recently at least, and perhaps still now, show me an advocate for people with long COVID or ME, and I'll show you someone who's either had it or who's someone in their family has had it, and whether it be a clinician or a politician, or it's always been through that close association, where for other more well-known conditions or more recognized like cancer, people's empathy has been able to spark and jump much further, hasn't it? But with these conditions, it's nearly always found closer to home.
Absolutely.
So partly then from your experience now, what does it take? What would it take, or what does it take to embed ME and long COVID knowledge of those conditions properly into undergraduate and postgraduate medical training, not as optional add-ons, but as core competencies? And, if you had the authority to redesign the curriculum in other institutions, what are the sort of top three changes or top three things that you would bring about?
I think I can speak to my personal experience on adding infection-associated chronic conditions and illnesses to our medical curriculum, and you do need to be a little bit patient. It does start off as an optional add-on. Our medical school curriculum gets changed every 4 years or so, right? They redesign it, they rethink it, they reimagine it. And so 4 years ago, I was saying it's time for us to add in long COVID and other infection-associated chronic conditions. And I was kind of laughed at, they were like, ha, 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 you're so naive. We've yes, we're about to change the medical curriculum. It is true. You heard right that we're about to like update it, but we've been planning those updates for 4 years, you know? So they said, what we can do is we can give you like this course and, you know, and it's an optional and blah, 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 you know? And so I taught that course for the 4 years and, well, 3 years. And it consistently had high feedback, and it consistently had like lots of people signing on to it, and people just enjoyed actually, you know, the younger generation of you know, trainees enjoy the complexity. They like the challenge of like a complex problem, you know, and of course, you know, like everyone knows someone with long COVID, so they're like, you know, I want to learn more about this thing. That and so, you know, from there, I was told, okay, we're going to add you to the MD PhD program, and you're going to give a structured lecture on infection-associated chronic conditions and illnesses to our MD PhD program and our PhD program. So that gets built in because the school decided it's a good idea, given that these are illnesses that affect so many people. We should expose PhD students to it if they want to study it for their PhD, and you know, and then as we've started to develop the medical school curriculum, now I'm starting to finally have conversations with the curriculum builders about the first year solid core curriculum, and getting one lecture on infection-associated chronic conditions and illnesses. So. You know, so it is this very sort of stepwise process where you need to show that it's, you know, engaging content, show that the students seem to genuinely want to hear about it. And
that's interesting in itself, isn't it?
It's
almost like a consumer model. Oh, will they enjoy it? Will they appreciate it? Will they give it 5 stars? And it's like, is that the, you know, is that the process here?
Well, it's an interesting, you know, like what I frequently get told is I push on these, pull on these threads and push these buttons is like, you know, listen, there's a lot of competition for what they get bombarded with so much content. Of course. There's a lot of competition for what should be added. So we need to be sort of democratic about like, what do people most want to hear about? And which is an interesting way to think about how you, but then when I sort of like bristle at that and think, I'm like, well, yeah, how else do you do it? You know, like, do you do it as a public burden statistic viewpoint, in which case, you know, the rare diseases will say, hey, we're missing out, you know, like,
how interesting. How interesting.
It was.
I guess what you're saying is, if you're going to have that model, you also need public awareness campaigns and everything, so to increase its salience with those trainees in the first place, so that they have something to tap it into, connect it with, and make it seem like it speaks to relevant experience in their life and like a problem that they want to be able to address. You know what? Going off script again a little bit, I'm just struck by the parallels, you know, my work, I'm not going to talk about it much, but is on climate change and sustainability education. And of course, you know, the educational, you know, the school curriculum is perhaps even more of a behemoth still in terms of any significant change. You know, has it changed much in 100 years? Barely. But, you know, even just, you know, even at this stage, knowing all that we know for decades, you know, still we just have reviews coming in say, oh yeah, maybe a bit, we can mention climate change a bit more in geography and science, maybe once or twice. And it's like, but this challenges our whole paradigm for how we do educate. It's not just a little add-on, you know, it's a problem, you know, it's something that we don't yet fully understand, even, and to the extent we do, we don't know how to fix it yet. And so it's a different paradigm for learning and acting. And, you know, these illnesses are something similar too, right? An education around them is like a space of not yet fully knowing, rather than just a handing down of information in a nice package ready for them to implement. So, it, you know, demands, you know, and like you say, that can be exciting. but it's very different from just even the way it's presented, perhaps from the way other conditions are.
No, absolutely. And to your parallel, it can be exciting and it can be extraordinarily daunting, to the point of existential dread. Climate change is something that if you read too much about it, you become full of dread. You're like, oh my God, what are my kids going to do? And what are the, whatever. When you start really digging into these infection-associated chronic conditions and illnesses, you start to think, oh my God, I need to stay healthy. I can't get sick. I need to, every infection matters. Every immune hit that I take matters. And it's a really, like, a lot of people come out of some of my lectures, if I give the lecture in a bad mood, terrified, and I think it's because it is such a huge, all-encompassing topic. I firmly believe that it's, in a whole population that seems to suddenly be obsessed with longevity, it's a factor that no one is building into their longevity models. None of the sort of like so-called longevity gurus are building into their longevity models. It's just like the simplest thing ever, which is, exposure to viruses, exposure to pathogens. How are you limiting your access? It's something that, again, to draw a parallel to climate change, if we want to protect our children, what should we be doing? We should be doing testing. We should be doing far UVC. We should be doing a good ventilation. We should be doing vaccination or vaccination alternatives such as monoclonals for post-exposure prophylaxis. And we should be doing masking if we're in high-risk environments. And I say if we're in high-risk environments for masking only because if you do all of those other things, you actually wouldn't need masking. If you actually said, hey, test your kid every morning, and if they show up sick with strep, RSV, CMV, etc., don't send them to school. If you did all of those things, masking, which everyone has fixated on and pitched battle stations on, either anti or pro, would actually be the least important mitigation if all of the other ones were in place.
And we wouldn't even need to do the other ones perfectly either. Each one would massively reduce, And even then, the masks were rubbish. Even then, they couldn't even get us to wear the right ones. But
No, I know. Yeah, and crazy. When I see a lot of the vitriol around masking, I actually, I often think about it. I often think about climate change. It's funny you brought up climate change, because I often think about like how when recycling came into vogue, we were like picking on people who wouldn't recycle, but the oil companies are getting like subsidies from the government, and it's like, if the government had, rather than saying, hey, it's on you, Jimmy, like put that plastic bottle in the right bin, and had actually said, you know what, we're going to invest like $2 billion into solar, and we're going to tax oil companies, like the problem would be much, much better than it currently is. And so I sometimes think about that. It's like, if you see someone in an unmasked space, unmasked in a space, rather than getting angry at them, get angry at the fact that we had a 2-year period where the government could have implemented, all governments, could have implemented incredible risk mitigation strategies for clean air that would have several generations thanking us for like good health. And we just failed.
It stuns me that people can't see the links between, the end of the 19th century drive to clean up urban water and, the drive and the drive now to clean air, that people, you just can't see the air, can you? And it's just, people can't connect with it in the same way, but, the logic is flawless. It's deeply frustrating. Anyway, I'm going to get back on script before I go. Okay. Otherwise, there's a whole like joint book in there somewhere about the parallels between climate change and parallelness, but we'll leave it for another time. So, patients often have a hard time trying to inform clinicians about their illness. what advice would you give to them about doing that? What sort of resources might be able you suggest that they look at or take, or indeed what sort of resources might those clinicians engage with to reduce the stress of that, or the friction of that encounter?
Yeah, it's a great question, and I'm always loath to put more work on patients, but sometimes this is the just the reality of the world. But I will start with clinicians because the reason we released our manual was again, it wasn't like this is the way to do things. It was just this is the way we do things, and if you were curious, now you can do it this way as well. And one of the things that we'll be updating in the forthcoming version of the manual, which should be out in the next couple of months, is we've added health coaches into the workflow, and what the health coaches do is they meet with patients, and we've created these little templates for patients for their appointments, and it's sort of very structured in a way of, what are the things that you most want to bring up? What are some of the pieces of evidence that go along with the, with the things that you want to bring up? So if someone, for instance, wants to try a certain drug protocol, what is the evidence that makes you want to try that drug protocol? So pop that into the plan. And so rather than saying here's a specific resource or here's a specific thing, because there's so much variation in what patients experience day to day, really what we try to do is personalize that planning of the appointment. And so my first advice to clinicians is having health coaches available is invaluable to patients. In the US, we're able to get it covered by insurance much of the time. It's not a whole lot of time and it's not a whole lot of money, but it's really, really invaluable and helpful to patients. And so if clinics and clinicians can achieve that is something that is really not just helpful for the patient, but helpful for the clinician, because then it gives an appointment that could have otherwise had no direction, a lot of direction. And it leaves everyone just a little bit more satisfied that the appointment went well. And
there's a cultural shift there as well, isn't it? Mediated, as you say, by the health coach, of sort of co-agency, if you like, that is still missing in many contexts and settings. To take you back to that image you presented from the beginning of the hypochondriac patient with the medical book under their arm. I and we here know of many examples of patients trying to come informed and with structure to their appointments, and then meeting hostility as if they're trying to take control or put the doctor in their place, and again setting off that panic response. That hold on, but I'm in control. And so but it's a cultural change you're describing, and the idea of it being mediated in that way is a really interesting one.
Absolutely. And to your point, which I think is a really good one and well taken, I mean, I think we also need a lot of providers to check their ego, because yes, this is the new way of doing things. Co-agency is in, and bodily autonomy is in. We can't throw these concepts around, and say that we believe in them and then not show that we believe in them with our actions in a clinical setting. And what we need is providers who actually walk the talk when they say that, okay, I co-design my clinic and my approach with my patients, and it's a partnership, and patients as partners. We hear that one a lot. If you're going to say that, you got to do that as well.
David, there's a sort of, what you're saying is really hopeful, and it also provokes a sort of sadness or wistfulness in me when I think, of another story in the UK press recently of another young woman at the brink of death with severe long COVID, with very severe long COVID, not being fed because she's been told that she should sit up and eat.
Yeah.
And that protocol doesn't allow them to feed her lying down. And there have been several cases like that. And the latest one, they managed to flee to another hospital with support where they were deigned to be fed.
Yeah.
But there is a whole other side to this, isn't there, where it breaks down into an authoritarian and sometimes deadly relationship, where all of those elements of misunderstanding and panic and control that we've talked about just flip the other way.
Yeah. You're 100% correct, and it's not my intention to go easy on those folks. There is some absolutely diabolical behavior that occurs in this space, and we've all seen it. Those of us who have worked in the space now, we've seen it. We do our part and sign petitions and write opinion pieces, and what I find the most tragic about this situation is progress is happening, and I do want to lead with the fact that progress is happening. There have never been more providers who are aware of these illnesses. I'm hearing about mast cell activation and antihistamine. There's never been this much good progress in the space, but we can't ignore the fact that there is still the tail end. These things always happen in a distribution, and there is still this tail end of absolutely unacceptably hazardous behavior to patients that has to be hunted down and struck out. It's when we hear about these things, in my opinion, we can't come down hard enough on the perpetrators of these human rights violations, because that's what they are, and they're happening out of sheer ignorance and unwillingness to adjust behavior with updated science, which is malpractice. So,
and that ego and people's power as well. People have positions of authority, don't they? And they have reputations built on holding certain positions, and in teaching other people certain things that come under threat from some of these conditions.
Yeah, absolutely. That is, I think I said earlier, the majority of folks, who are presented with the education that I provide, typically you see them in the audience and they're nodding their heads and their eyes are wide and they're taking in the information and they're like, wow, but I will say there's also, I'd say, one every 3 talks, there's always someone in the back, arms folded, frown on their face.
Yeah.
And invariably this person will always approach me and they'll talk about, psychosomatic symptoms, and they will talk about, they'll talk about FND, and they will talk about cognitive behavioral therapy, and they'll talk about unhelpful illness beliefs, and they'll talk about their successful practice, always their successful practice. And as soon as I hear successful practice, I'm like, oh, so you're just here protecting your turf. The only reason you're arguing with me is because you don't want, clients taken away from you. Whereas the difference between me and you is, if I'm wrong, I want my patients to go elsewhere and get better. If they can't get help with me and at my center, I really want it. All I want is for them to go off and get help somewhere else. I would never stand up and say, even though you're helping someone, I think you're wrong, and it's all about me. So that's ego, that's greed, that's medicine for all the wrong reasons.
Yeah, and you can always ask, well, what's the graded quality of the evidence that you're relying on as you make that judgment?
Yeah,
because that's what that research doesn't have, does it? And that's what it's been. But I'm going to reconfigure my last couple of questions because I think partly answered them. But but what you're saying, because what you're saying is you're giving us a postcard from a place where things are changing, and there's some really hopeful practice and really hopeful cultural change going on. And I think things are very different in other countries and other places, perhaps in the US, but also in other countries too. And there's very varying practice from country to country, as you have those different contexts. How is the work that you're doing and that colleagues are doing starting to spread out beyond your borders and reach out, across the country and internationally through remote learning and that sort of thing? What are the prospects for that?
Yeah, I think yes and no. We are definitely giving a lot of international presentations. We're definitely getting out there and and talking about things to colleagues internationally. I would say, full disclosure, as an Australian who grew up with socialized medicine, that worked, in my opinion, very, very well, by the way. Like, I don't know, like a lot of these expats go, oh, well, terrible system. I was like, yeah, it worked for me.
A lot of it's funded well.
Yeah. And now I've worked in the US system, which has its bright spots and its dark spots. I think you get a bigger distribution of care quality in the US, but it's a bigger distribution. Both tails are longer. One of the things that I'll say, if I could wave a magic wand and change things in the NHS or in Australia or in many parts of Europe where there's sort of single payer systems and socialized medicine, I would say that the sort of right to try and the ability to easily prescribe off-label medications really needs to change, because I view that in my presentations, in the responses and questions that come to my presentations, that seems to be the most common thing, is like, oh, well, it's okay for you in the US, you can just prescribe things, and it's it's on you, you can do that. Evidently in the UK and in Australia, it's much, much harder to do something like that, and people can come for your license, and it's quite strict. So that would be one thing. And then the other thing is, excuse me, the other thing that I find a little bit troubling is, or problematic for care here, is that there is the patient has a little bit less autonomy in socialized health environments about what they want to do. It is a lot more pathway driven than a system where you can actually say, you know what, I'm going to go and pay for it myself out of pocket, and come what may. So those are things that where we differ a lot between the countries, and these two things seem to be a barrier to uptake of a lot of the strategies that we're finding useful,
right,
in the UK. And
so once those structural barriers are removed, then the messaging will get across more easily, you think? So at the moment, people might be hearing it and think, well, we couldn't do that.
Couldn't do that. Yeah.
Okay.
I mean, I don't know. I don't know. I just have hearsay. But I mean, even some of the stuff that we talk about with antihistamines, it's like, it's radical. Like just the idea